say the title, Cope with Cryptozoospermia and Strategy of Cryopreservation. But I would say the main part will be, first of all, to deal with difficult ICSI. As you can see, this girl is searching after spermatozoa for more than 8 hours, and she's tired. And we can talk about difficult ICSI, and will be the objectives of the presentation when we faced in the ejaculate cryptozoospermia, complete azoospermia, severe teratozospermia, high degree of DNA fragmentation and anomaly of the chromatin, and also in case of azoospermia, and also difficult ICSI when we have to face with a limited number of spermatozoa that were cryopreserved before, in case of severe oligo of cryptozoospermia, and also in case of testicular biopsy. And today I will focus my presentation first on the cryptozoospermia and complete astenospermia and azoospermia, and see the strategy of sperm preparation. And in the second part of my presentation, I will deal with the cryopreservation of limited number of cryopreserved sperm. So, male infertility concern around 50% of the infertile couple, and we can see that the percentage, the concentration of spermatozoa all over the year decrease, and mainly due to pollution. And I hope that if this line continues, this will be not the end of Sapien. But be optimist. So in 1892, there was a spectacular progress in the therapeutic management of patients with severe alteration in sperm parameter, and so Palermo introduced the ICSI procedure. But we have different kinds of sperm that we have to deal. And one kind of sperm that we have to deal is cryptozoospermia. That means extremely low concentration of spermatozoa. And most of the time we have to centrifuge the sperm and check in the pellet if sperm are present. This is the normal sperm preparation for moderate OAT. That means a centrifugation gradient percol, followed by swim up, and we place afterwards the sperm in an ICSI dish. But this is not possible to use such methodology for cryptozoospermia sperm. In such case, first of all, as I told you, we centrifuge the sperm, check in the pellet if we find some spermatozoa, and afterwards we share the pellets in several columns with only one layer, 90% gradient. Why such amount of columns and one layer? In order to, I would say, dilute the debris, the round cell, red blood cells that would be present on the layers, and avoid the saturation of the layers, in order that we are sure that some spermatozoa can go through in the 90% gradient. If we know in advance, during a previous staff meeting, before that we start the IVF cycle, that we have to treat such a difficult case, we organize the work in a way that the treatment and the search for spermatozoa start before the oocyte pickups, because it takes time. And because what our objective is not to avoid oocyte aging, that after the oocyte pickup, that we don't have to wait too long to search spermatozoa. In case that we have to wait too long, we consider then oocyte vitrification. Also, for such kind of sperm preparation, it is an extensive lab work. We try to obtain a final suspension with few debris from cells, germ cells, erythrocytes, because we want to avoid that all these kind of debris may stick on the injection pipette and make the ICSI quite more difficult. Therefore, we have to be aware that the quality of the preparation will determine the time that we will spend to perform the ICSI, the management of the oocyte out of the incubator, not to the oocyte don't have to stay too long out of the incubator, and we have to avoid the aging of the oocytes. Our rules in our center is vitrification of oocyte, maximum 3 hours of the oocyte pickup. If impossible to give the semen sample without 3 hours, vitrification of all the oocyte or at least one part. This is how we prepare the dish, ICSI dish, in case of class normal ORT semen. We perform swimming of the sperm in a snake drops, we call this, but in case of cryptozoospermia, we place some microdrops in the dish and we try to find spermatozoa in each microdrops. But we can have cryptozoospermia, but together also asthenozoospermia, and this makes the life more complicated. And if we observed complete immotile sperm in the first ejaculate, we ask for a second ejaculate. And in the second ejaculate, we can also observe 100% immotile sperm. So what we do, we look better, and is it a virtual or absolute asthenozoospermia? And in a majority of cases, I would say, we find after extensive processing of the semen, some motile spermatozoa, and we can perform the ICSI. But we observed also sometimes absolute asthenozoospermia, and then question mark regarding ICSI-IMSI. In fact, absolute azoospermia may be associated with complete necrozoospermia, ultrastructural abnormalities of the flagellum, Carter-Jenner syndrome, but in general, I would say when we have Carter-Jenner syndrome, the concentration of the spermatozoa is higher, or then we have plenty of different reasons and etiology that may explain the absence of motility. So, in such case, we have to perform before ICSI-IMSI vitality tests. And for example, we have different tests, the hypoosmotic swelling test, mechanical touch of the flagellum, motility enhancer with the inhibitor of the phosphodiesterase, thiophyllene or pentoxifylline, the laser touch, also birefringence. In our center, what we do, first of all, we applied pentoxifylline or thiophyllene. We checked if we find motile spermatozoa in the drop. If the spermatozoa are not motile, what we do, we remove a small part of the media and place back after an hypoosmotic solution and check if we find hypoosmotic swelling test and check if we observe some curling tail. This is the way how we perform our the sperm analysis. So afterwards, okay, if the vitality tests are totally negative, that means necrozoospermia, we stop, we don't perform the ICSI-IMSI because already more than 25 years ago, one of my colleagues, Martinez, has shown that no ongoing pregnancy with totally immotile spermatozoa from the ejaculate and even epididymis, spermatozoa that were necrozoospermia. But if we are to face with such situation, what we have to propose then, surgical sperm retrieval. But surgical sperm retrieval in an unforeseen situation, it is complicated because most of the time the patient, we have no fasting patients, or also for the organization of the doctor, it is a big problem. So I would say in 50% of the case, the only solution is to perform oocyte vitrification. But in case that we perform testicular biopsy, Then the doctor is able to do the oocyte pickup. The patient is already prepared. But first of all, I want to, I would say, say some words about my previous boss, Professor Skursman, with whom we obtained the first pregnancy with testicular sperm. It was a very famous embryologist. And so we perform testicular biopsy, and in case of non-obstructive azoospermia, the doctor, according to the doctors, some prefer testicular extraction one biopsy or the multiple biopsy, and some doctors microdese. So we in the lab, we receive different kinds of tissue, one piece, several pieces, or seminifer tubules. And the first important step that we have to do is to wash several times the tissue in order to avoid and to reduce the amount of red blood cells. Because I observed in some lab what happened, they receive the tissue and directly they start the scratching of the tissue in the middle of plenty of red blood cells. Can you imagine afterwards the complication to find spermatozoa between all these erythrocytes? In the second steps, after cleaning very well the tissue, we start the scratching, mechanical processes of the testicular tissue with needle, or with slide, or with a filter, we scratch in a filter, or with a potter, scratching in a potter. And after that, we perform vortexing. In our centers now, we apply mostly fine mincing with needles. In case that we don't find spermatozoa in the tissue between the different cells that were scratched, we add then collagenase to induce an enzymatic testicular tissue digestion. Also, but we never use this technique, but some propose it. In case that we have a lot of red blood cell, you can add some red blood cell lysis solution. Now, after this step, we check on the microscope if we can find some spermatozoa. We inform the surgeon about the presence or not of the spermatozoa then. And after that, we place the tissue, the mixed tissue in on the gradient. If we find spermatozoa, then we place the tissue in general on 4 columns with 2 layers, 70% and 90%. If we find no sperm, then we try to dilute more in order that the sperm, in order that the possible sperm that are present are not stopped by the different tissue. So we try to dilute more. We perform then 4 to 8 columns and only 90% gradient. Afterwards, centrifugation for 20 minutes. So then we made the ICSI drop, the ICSI dishes with the micro drops. We check in the drops. If we find no spermatozoa in the drop, directly we perform oocyte vitrification. In case that we find spermatozoa, but no motile one, then we perform also the vitality test, as I showed previously. If it is negative, oocyte vitrification. But in case that we find motile spermatozoa, then we perform the ICSI-IMSI. If the vitality test is also positive, we perform ICSI-IMSI. But in this case also, we are very careful for the sperm because we will afterwards, if possible, freeze, cryopreserve the sperm that we still have over. In general, in non-obstructive azoospermia and in case of cryptozoospermia, we freeze a small numbers of spermatozoa. Also, we have cases with diagnostic. So we received, then the men came in our center and provide 2 semen samples with 3 months interval. And after washing and concentration of all the egg ejaculate, we search for spermatozoa in the suspension. If we find no sperm at all, then this patient and his wife will start an IVF cycle with surgical retrieval some weeks later. But in case that we find some spermatozoa, we will then freeze the spermatozoa that we find. So what you see, that freezing a small number of sperm is finally a procedure that we do often. I would not say that the percentage is higher, but sometimes we have to do it. And we do this in case of cryptozoospermia of severe oligozoospermia, in case of azoospermia, mostly in case of non-obstructive azoospermia, and the ability to cryopreserve small number of spermatozoa avoids the requirement for multiple TSA. Then also case to freeze small number in case of preserving fertility before chemio or radio or surgery treatment. And also in case of idiopathic forms, we have sometimes a patient that gives us a normal sample, and after 6 months with a huge reduction in the quality of the sperm, in such case, we cryopreserve also the sperm. But cryopreservation, no, the second part, how it works. When we have, for example, a sperm with more than 5 million spermatozoa, what we do, we expose the ejaculate to cryoprotectant, the normal solution that you can find in the different companies, a solution in general with glycerol, and we place the sperm inside a straw. When the concentration decreases between 1 million and 4 million and less than 1 million, what we do, we reduce the drop of media that contain the spermatozoa. The aim is, the objective is to know when we will perform the warming, we know where the sperm will be located. And this is very important. Afterwards, we perform the conventional freezing method, the straw 8 centimeters above the liquid nitrogen, 10 minutes in the vapors. In case that we have a testicular biopsy, what we do, we can freeze the sperm, but in general, if we find spermatozoa directly in one part of the tissue, we work with this part of the tissue, and we cryopreserve the different seminiferous tubules that we open slightly, and then we aspirate the seminiferous tubules in the straw. Then in such case, 15 to 20 minutes equilibration with the cryoprotectant solution. So, but what are the drawbacks of conventional cryopreservation techniques? The conventional cryopreservation techniques, that means loading the sperm in the straw, are inadequate for preserving rare spermatozoa and can result in sperm loss due to sperm adherence to the inner wall of the straw, harsh centrifugation post-warming, washing procedures post-warming, and dilution in large amount of media, which might require or of microscopic screening to locate sperm and motile sperm after warming. So the challenge, therefore, is to cryopreserve a small number of sperm, and that means the search of rare spermatozoa. Okay, then we have to find easily, after warming, enough spermatozoa. And the objective is that we have to know where the sperm are located on the device. That means this concerns the technical aspect and the carrier system. And the second step, also, we have to, this only sperm that we find there has to remain viable after warming. So we have cryopreservation protocol, the conventional with above the vapor of the programmable freeze protocol versus the vitrification. So now in the literature, you have a nice review concerning all these steps. But we have then to deal with the carrier and the cryopreservation procedure. And first of all, let's go to the carrier. We have first of all biological carrier. And the first one that was proposed already almost 25 years ago by the team of Jack Owen was cryopreservation of single human spermatozoa in an empty zona pellucida. That means that he had oocyte, unfertilized oocytes. He empty with a pipette, remove the cytoplasm, empty zona pellucida, place back spermatozoa, and then the zona pellucida was cryopreserved in straw mode with the conventional freezing protocol. So different literature has shown that you can use human, hamster, mice oocytes, mice zona pellucida, and with this method, ejaculate, testicular, and epididymal sperm were cryopreserved. The team of Cohen finally observed and obtained pregnancies using this technology, 30% implantation, similar to fresh mesothese and similar to neoclassical conventional ICSI. Then afterwards, there was another way, the Volvox globator was an alternative in countries that prohibit the destructive use of oocyte, even after fertilization has failed. And this happened in Germany and in Austria. So this is a kind of algus that you place in culture, and they came together and they produce a kind of sphere. And inside this sphere, you introduce the spermatozoa that was after cryopreserved in a straw. After the biologic carrier, we have the non-biologic carrier. That means principle of encapsulation, and this, I would say, artificial zona pellucida, and they mimic the zona pellucida. We have different types: alginic acid drops, agarose, gel microsphere, and you can see this is nice, look like zona pellucida. They introduce one spermatozoa inside, and this is a nice also this hyaluron phenolic hydroxyl capsule, and I would say it is like also zona pellucida, but the advantage of this technique is that when you warm back the artificial zona pellucida, I would say you place afterwards in a solution of hyaluronidase that will dilute the hyaluronic acid. And so you know in your petri dish you can have a look and you can see your spermatozoa under the microscope during the removal of the zona pellucida, the digestion of the zona pellucida with hyaluronidase. After that, I will come back on the drawbacks of all these techniques. So, with all these techniques, this exposure to the solution of cryoprotectant, in general glycerol, before loading in a straw and cooling above the vapor. And after that, we have another carrier to deposit the rare sperm. We call this the rare sperm microdroplets freezing methods. It's in polystyrene and propylene carrier device, and we have different devices. The sperm is deposited directly on this device that contain cryoprotectant or simple media that has been previously deposited on the carrier device. So here it's cryoloops. You can see here there are quite a lot of spermatozoa, but they deposit with a small drop on the loops, and after that they place back in a cryovial. Here we have the sleepers. It is a kind of polystyrene plastic, and you place a small drop of media and you deposit afterwards the spermatozoa in this drop, and you insert this one in the cryovial and plunge afterwards, or you perform vitrification or above the vapor. Then you have the plastic petri dish. This is a very old technique that was performed by well-known Jacques Testa from France, and he directly placed the sperm in micro drops in a petri dish, and he performed the cryopreservation of the petri dish. Then we have the cryotop, well known for oocytes or embryo cryopreservation. Then we have different devices, the cryoleaf. All is based on the same principle, but the different shape of polystyrene slice. The last one is from Berkovic, also kind of small micro drops that you can place in a device that you introduce also in a cryovial. So, what condition the cryopreservation method must meet to be effective? Fast recovery of the spermatozoa post-warming, high recovery rate, high survival motility rates, easy handling method, does not take up too much storage space, and aseptic storage is important. And first of all, we can see the recovery rate according to different type of device, and you can see that the majority of recovery are between 80 and 100%. So I would say it works quite well to recover the sperm. And the motility rate, but I would say that the motility, this is percentage that I take from the literature, but we don't know exactly the initial motility before the cryopreservation in most of the cases. But you can see that we quite an average of 50% of the sperm were motile after warming. But the drawbacks of the device for empty zona pellucida, this exposure of human gametes and embryo to rodent zona, sperm can bind to the ZP3, leaving some host DNA fragment behind. So it was not possible to continue, and the same with the algae, because it was unacceptable in a clinical setting to store human sperm in algae. The other artificial zona pellucida, today almost no clinical data. The different device, plus the plastic device, few clinical data excepted for the one of Berkovic. It obtained 30% implantation. And then the plastic petri dish, the cryotripling cryoleaf, this non-aseptic, not hermetically closed. Our experience, what we do, we use VitriSafe, the device that we use for freezing oocyte and embryo. What we perform, we place the sperm in the gutter with a stripper. Next, we place the cryoprotectant, solution of glycerol. We make a mixture. We place them back directly in a protective straw. We seal it, so both are sealed. And exposure 15 minutes to 20 minutes at 4 degrees or 10 minutes at room temperature, and afterwards above the vapor. To remove the sperm, what we do, we warm at room temperature, and with a stripper, we aspirate gently this drop. We place this drop in the middle of the petri dish. Then afterwards, we place some drop of media, medium in the surrounding of the sperm drop, and afterwards we perform We make small bridges in order to dilute the drops, but we know that the spermatozoa will be located there. Afterwards, we place the PVP, the EFRE drops to the injection drop. We cover with oil and we wait a little. If we find no motile sperm, we add afterwards pentoxifilide. So the results with this, this is for example, we calculate with low number of spermatozoa. We don't give a number in concentration. We say we find 1 sperm per 10-15 fields. Observation 400. That means that we realize more the difficulty that we will have. So in total, we perform 38 cryopreservation, 30 warming, and until now we got 8 birds and 2 ongoing pregnancy birds still lost. In some cases, we don't have enough spermatozoa, and then we have to perform vitrification of the remaining oocyte. Also, what I want to say, not to forget, in case that we warm spermatozoa, in such case, we perform also all the time oocyte activation, because we know that during cryopreservation, all the system of the cytosol that contain the PLC zeta, the activating factor, may disappear. So, no, slow freezing or vitrification. Actually, why vitrification might work better than oocyte on embryo? Because the quantity of water in the free water in the spermatozoa is very, very low. So the chance of crystallization probability is quite low. But finally, until now, there are some articles were published, but I can say that there is no yet huge data showing the superiority of vitrification compared to the classical cryopreservation method. Also, we have to take care, also cryodamage can also alter the mitochondria by ROS production, and also different aspects of the protein, mRNA, genome, and epigenome. So there are still plenty of study that has to be done for the future. The conclusion: processing for semen quality is not an easy task, because we have to face a lot of unexpected situations. Unexpected cryptozoospermia, azoospermia the day of the oocyte pickup, absence vital sperm in the fresh or frozen biopsy, and difficult cryo procedure. Oocyte vitrification now makes it possible to reduce stress and deal with unforeseen situations. In case of cryptozoospermia or non-obstructive azoospermia, the challenge for the cryobiologist is to optimize all the steps to make ICSI less difficult and find rapidly the rare vital sperm. So we have to adjust the sperm preparation method to optimize the source for spermatozoa, optimize processing of the harvest tissue for fresh ICSI or cryopreservation, use in an adequate way the vitality test. Master the cryopreservation of spermatozoa for crypto and asynchrone biopsy. In case of asynchrone biopsy, we have to promote small number of spermatozoa in a minimal volume, in an hermetically closed device, in a straw instead of a cryotube for space storage reasons. Conventional freezing versus vitrification is still in debate. For the future, maybe we have to apply defensive strategy to protect the sperm cells against damage. So, the biologist is not a robot, but still a master of craftsman. A good collaboration between the medical part, the biologist, and the coordination personnel is mandatory to optimize all the different steps. I want to thank all the people from Austria and Belgium, and thank you very much for your attention.